Cape Coral Hospital ICU, and usually every shift I have some sort of practical lesson or teaching points or something. So first is going to be the importance of really, I mean, what we're here for. And it's not necessarily what we're going to cover today, but I had a patient last night that through just understanding basic concepts of what I teach, I'm confident that even my students on rotation would have picked up on what was going on and would have prevented the patient's arrival in the ICU. So patient comes in, and I'll teach you about urinalysis next semester. Patient comes in, febrile, and a little hypotensive and tachycardic, and has a urinalysis that shows large leukoesterase, leukocyte esterase, which is a product of white blood cells in the urine, which don't normally belong there, and comes in weak. So you presume he has a urinary tract infection. So he also has some slight acute kidney injury. It's an evidence of dehydration, which is not uncommon. It's actually pretty common. Maybe 40% of the time it might present that way. So he's dehydrated. He has a urinary tract infection. He's tachycardic. He's febrile. The ER, I imagine, checked the lactic acid, which is something that, I'll teach you guys. Lactic acid is a product of anaerobic metabolism. In sepsis, what happens is there's some degree of anaerobic metabolism. There's dysoxia, I think the term would be. Basically, metabolism is deranged on a cellular level. So one of the things you check for, to check for sepsis, which is exaggerated inflammatory response to infection, you check for lactic acid. This patient's lactic acid was 5.4, which is elevated. Anything above 2 is elevated. Anything above 4 is concerning. And they admit him to the floor. And they kind of forget about it. And then last night there was a call because he went into cardiac arrest. So luckily, they picked it up quickly because he was on telemetry monitoring and went down there. ICU nurse goes down there, finds out he's also hypoglycemic. They give him dextrose, they give him epinephrine once, and they get pulses back and bring him to the ICU. Lesson to be learned. Know how to recognize sepsis. Obviously, we're not covering that right now, but it's something that's of exquisite importance for any practitioner in any specialty to recognize sepsis, because if you don't, then you're part of the blame of why the patient has a bad outcome. So, sepsis. We won't go over it. You can look it up on your own if you want. It's SIRS plus suspected or confirmed infection. What's SIRS? You can look that up. We'll go over that some other time. So that's lesson number 1. And point number 2, generally speaking, I know that, because I remember being in the shoes, you're looking ahead at clinical rotations, you get excited, so you want more information. Sorry.
Just curious, under whose responsibility was that patient? You said he was in the ER, but you got admitted.
Mm-hmm.
So who was looking over?
At that point, it's the hospital. It's the main. It's really, if you look at it really from the most practical sense, if something ends up becoming a lawsuit, it's everybody who touched the patient. So if you came and went and you said, this is what's going on, you're fine, and you walk away and you missed something major, like, we had a patient who recently died as a result of probably about 4 or 5, there was a mix of PAs, NPs, and physicians who missed the fact that the patient had 0 neutrophils. Absolute neutrophil count is 0. You'll learn about that. That means he has basically no functioning immune system, right? Everybody missed it. So everybody who touched the patient who looked at the labs would be liable. In that specific situation, probably most of the blame would rest on the failure of the rounding internal medicine service to pick up on it, act appropriately, resuscitate the patient. That patient gets a lot of IV fluid, broad spectrum antibiotics. And the way we function at Lee Memorial is that patient goes to the ICU. We take anybody in the ICU who has signs of sepsis. So, that's, the best I can break it down at 2 o'clock in the morning. But, it's the importance of really, there's certain things that I'll stress that you can't miss. And, not only is probably an indication that I'm going to test you on it, but it's also literally stuff like IC that's egregious, that if you miss it, it really makes You look bad, the professional look bad, and it's not something I would want ever to happen to myself or a family member, because it's just something that, it's low-hanging fruit. It's really easy. If you see a lactic acid of 5.8, you should be like, oh my God, that's crappy. Apparently, nobody thought that was crappy, and the patient just ended up on a regular floor, regular bed, and was there until there was a bad outcome. So, rotations. You know, even in May and June, the class that was about to go into rotations, when they had questions and requests, my answer to them was, no, not yet. You know, rotations, because we do take requests, and because we do try to send you where you want to go, especially for your electives, requires a lot of manpower and woman power, I guess, because it's two of them are ladies back there. So people power, requires a lot of people power. So our priority is with the class that's currently out, because even setting up one rotation out of state can take months of back and forth. So because of that, when it does come time to elicit requests and whatnot, you know, trust me, we'll let you know. We'll tell you, hey, it's time, think about yada yada. In terms of general information, that'll be probably try to do it late spring. It just depends on how we're doing with the class that's currently out. You know, I've recently really taken it over, and I'm one who likes to do things ahead of time. So whereas in the past we would confirm for the next rotation, it would be typically like the week before or the end of the week before. This time around, I think we had rotation 2 confirmed about 2 weeks before the rotation started. I'm already trying to get rotation 3 confirmed, and rotation 2 just started yesterday. So hopefully, by the time we get to next late spring, next early summer, we'll kind of, everything will be set up far enough ahead of time where then I can start concentrating on you guys. But like I told the guys before, and hopefully they'll be, again, things will be set up ahead of time. The priority is in the class it's in and the class that's going to graduate, because you would want the same attention as well. If you're not 100% set up, do you want me putting energy somewhere else? Do you want me to be like, well, I'll get to them, it's okay, they graduate in 3 months, but let me get to these folks who don't graduate for 15 months. You know, the priority is to get you through and get you out, because the reality is that preceptors do change their mind, and it happens at the last second. Or something happens, the preceptor is going to go away for 2 weeks, but they don't bother to tell us, and it's nice if they tell us, but you know, I'm not going to go yell at them if they don't tell us. So, like today, last couple of days, I've had 2 students who suddenly have situations where they're not going to get enough exposure. Now I have to find something for them. You know, I've got to scramble and change things. So rotations are a dynamic process. They're always changing. They're always requiring energy. So it's hard to predict several months ahead of time, let alone a year ahead of time. So I would, like the series, if anybody wants, curb your enthusiasm. Curb your enthusiasm. Concentrate on the now. General information, I'm happy to talk about general information. Specific information or specific requests at some point, you know, then I'll tell you, that can't be answered right now. I would, and then direct anything to me and not to the coordinators who really literally are spending all day long in working on the people who are out there now. So it's not yet time to contact them, not yet time to request anything, but if you want to have a casual conversation about it, you know me, I like to talk. I'm happy to have a casual conversation. And I'm also the type that, I don't know if you realize it yet, I know the previous class certainly does, I will tell you what's on my mind, I'll tell you like it is. I'm really not afraid of being politically incorrect in terms of really just giving it to you straight. Again, if you have a problem, okay, you're entitled, and I don't know. I just feel, when I was in your position, I really just tell it to me straight. If you hurt my feelings, at least I prefer that than something sugar-coated and you realize that it was just all big sugar-coated lie. And that's just my personal personality. I can't speak for anybody else. Any questions? No? Seeing none. So anybody have any, I know there was one question that was emailed to me that I figured I'd wait until I address it with the class, because I do know that, you know, I speak a lot from stream of consciousness. And, so I recorded integrity. And I know one of the things which I probably stressed because of the fact that it's something that's done and can get misinterpreted a lot is the concept of the BNP, the brain natriuretic peptide, the blood test for heart failure or to predict heart failure. So, I mean, it's this paradox that, yes, sir?
You call it brain, I've heard of, I mean, I looked it up, and is there any difference between the brain
And the atrial?
Beta?
So there's, I'm not sure if you're talking about the pro-BNP, there's a pro-BNP, there's a regular BNP, but what else? So if it's not one of those two, I'm not sure. Because I know Lee, we do what's called like a pro-NT-BNP or something like that, something to that effect, but otherwise I'm not exactly sure what you're talking about.
We both just heard it called like the B type or beta type.
I just googled it and said one said brain, then on the Cleveland Clinic website says B-type intrahepatic hepatitis.
I think those are synonymous. I would say those are synonymous, but I'd have to look it up because ordering it, it's just we order the BNP, and the way I've heard it referred to usually is the brain natriuretic peptide, but I would consider those synonymous until unless you hear otherwise for me. So, blood test ordered to predictive heart failure is what's going on. You have to, just like the troponin, just like anything else, when you order a lab, you have to take it in clinical context. You have to consider the history, you have to consider physical exam findings, and then does it make sense in context? There are sources of error. With BNP, this is something we see extremely frequently, very common sources of an elevated BNP that have nothing to do with somebody having decompensated heart failure, pulmonary edema. Number one that we see is sepsis. People who are septic, people who are actually the opposite, people who are dehydrated and volume depleted. The BNP is going to be elevated in a lot of cases. And why? I would maybe put it in this perspective, and if you think of it this way, it hopefully will make sense. So commonly in sepsis, commonly in volume depletion, physiologically what happens, the myocardium, if you did an echocardiogram, which we'll do, especially if we have a clinical question, the term used for how it's behaving is hyperdynamic. It'll be hyperdynamic. So hyperdynamic, I mean literally it's just what you think it means when you listen to it. It's beating vigorously. It's really trying its best. It's trying to squeeze every last drop out. It knows we need more blood. Why? Well, maybe because of the tissue hypoperfusion, those patients with the elevated lactic acid. And again, it just, with the inflammation, with the infection, what ends up happening is there's an attempt to raise the cardiac output. You try to raise the stroke volume. So you end up having a hyperdynamic heart until that sepsis gets resolved, until you give more fluid. So BNP will raise in a setting that would cause stretch of the myocardium, a situation with overload. So if there's too much fluid in there, the myocardium stretches. So think about the myocardium stretching from overload, and think about the myocardium and its behavior when it's hyperdynamic. And the way I reconcile it in my head to remember it is that both of those situations are physiologically similar in terms of what is mechanically happening with the heart. So if you look at it that way, for that reason, you can deduce that in sepsis. And this is paradoxical because you think BNP, volume overload, heart failure, but in sepsis it's the opposite. They're dehydrated, yet the BNP will elevate. So in the absence of other findings that would suggest heart failure, I would be careful with the BNP. So other findings like peripheral edema, other findings like pulmonary edema, elevated jugular venous pressures, displacement of the PMI. So it is a really good test if your pre-test probability is high. If you really think it looks like heart failure, it's acting like heart failure, now let me check this. And you can theoretically also use it to trend heart failure. What do you mean by that? So, especially before the pro-BNP. The pro-BNP is very sensitive and it's not as good to trend. But what we used to do, even when I graduated, the regular BNP, anything above at the time, I think it was about anything above 100 was clinically significant. Now the new assay, the new pro-BNP, it's like anything above 1800. It's all out of whack. It's all weird. But the cardiologist, or we would order daily BNP, and you get a sense of if it's going down, they're getting better, if it's going up, they're getting worse. You really can't do that with pro-BNP because it's so sensitive and picks it up over a longer period of time. That was the first thing when that assay came out at Lee, that the education that they gave us was it's so sensitive you can't really trend with it anymore. So, renal failure is going to be another common situation. So if someone, because BNP, that substance, is cleared by the kidney, so somebody who has renal failure can have an elevated BNP where that may not be as clinically significant as it otherwise would have been. But Dr. Guzman, in renal failure, if you have end-stage renal failure, you're not urinating, so couldn't you actually have a truly elevated BNP in the setting of renal failure because of overload, because you're not urinating? Yeah, yep, that's right. So how do you reconcile the two? Yep, that's right, physical exam findings. I know somebody thought it. So physical exam findings, if you have somebody with edema, you have somebody with edema pulmonary, edema peripheral, then the BNP will be helpful. It can confirm to you, yep, they have rip roaring heart failure, we have x-ray findings, we have physical exam findings. So then why is it useful? That's where you get my bias. I'm not really sure it is, because the diagnosis really should have already been made on other counts. You're not saying, well, they're short of breath, but I don't know why, let me order a BNP. That's actually how it gets done a lot. I would tell you, be careful, because it can be misleading. So yes, it's sensitive, and its specificity I question, but in the right setting with high pretest probability, it's good in heart failure. But at least now, if you see an elevated BNP, you have to be critical. You know, what's going on? Or if you're going to order it, again, you've got to look at it critically. Do I really think this is heart failure? You know, maybe they have signs of, you know, again, I'm trying to give you a theoretical example. They have some signs of failure. They have some edema. You listen, you hear crackles, but they're coughing, and they're coughing up sputum, and they have fever. And you're like, all right, well, is this pneumonia or is it heart failure? I would treat it as pneumonia, first of all, no matter what. But you can check, and maybe if they have a really elevated BNP, and then, you know, you have bad lung sounds, you have some edema, maybe heart failure is a component. But if you really want to confirm the diagnosis, you guys are you doing cardiac yet, or is that starting soon?
We're in it.
Okay. So if you really want to confirm the diagnosis, then what's a non-invasive test you can order to really get a sense of if heart failure is what's going on? The echo. So if you have a question, get an echo. So again, the BNP is going to be a tool in your armamentarium, but if you want, as long as you understand everything in context, then you're not going to make an error. You know, I mean, it's a tool you suspect. If you're not sure, then you just keep going further with the diagnosis.
Can you enhance it with like a non-invasive cardiac monitor, like a cheetah, or?
That's a very good question. So that'd be an advanced question beyond the scope of general PA practice, but you know this because of being in the unit. So the question is, could you get your diagnosis or get more information by using a non-invasive cardiac monitor? Are you guys actually, was that concept introduced to you in the cardiac module? All right, so one of the things that we do have in the intensive care unit, back in the day, what was done very frequently was something called a pulmonary artery catheterization. That I'm sure you've heard even at least once from me, I think. So you end up putting a central IV line, goes in the internal jugular vein, and when you feed the catheter, you think your anatomy, it's going to go into the superior vena cava and into the right atrium, and if you keep feeding this pulmonary artery catheter, then it goes into the right ventricle, and it goes into the pulmonary artery, and eventually that artery gets smaller and smaller and smaller, so that catheter will wedge. And then when you get pressures, you assume those pressures are related to the pulmonary circulation. If it's elevated, then again, well, you have elevated pulmonary pressures, that means elevated hydrostatic pressures, that'd be consistent with pulmonary edema. So we use pulmonary catheters to get cardiac output measurement. You can deduce stroke volume through calculations that the machine will do. You can get peripheral resistance, and these tools will give you information that can help tell you whether someone has heart failure or whether it's sepsis. Again, beyond the scope of this class for me to teach you that. So then they have these non-invasive things also, where you just put these electrodes on folks, and it's a transducer basically, I think, and what it does, it measures, you know, non-invasively fluid flow up and down. So you put pads here, like near the shoulders or back, and then down here in the lower abdomen. And using those numbers, if someone has I think the peripheral resistance is going to be high, but then the cardiac output is going to be low. I mean, looking at the numbers, you can deduce whether heart failure is what's going on. The short answer is, well, yeah, you could in the right setting. I don't know that it's done much in ambulatory medicine or on the floor even, but in the intensive care unit, it's a tool that you can use, non-invasive cardiac output monitor. The brand that we use is Cheetah, just like it sounds, NICOM, N-I-C-O-M, Cheetah. So if you're really curious, you can look it up. They have a PDF somewhere on the website that really explains, and it's meant for like nursing and everybody, so it should explain it. You should be able to, even you guys can understand. It'll explain, yeah, you're welcome. It'll explain, talk to me when you pass your pants. So anyway, so you give me sarcasm, I can give it back. So, but on there it'll give you, like, if the cardiac output's high, if the cardiac output's low, if the SVI is high, if the SVI is low, if the TPRI is high or low, what possible things it could be. That's really beyond the scope of what we're supposed to teach you, which is general medicine. Anyway, a little bit of a tangent, but I think this today should be relatively quick. Cardiac enzymes are relatively straightforward. Any questions so far? I hope BNP makes a little bit more sense. It's really a test that you have to take in context with clinical exam findings. That's the take-home point. Don't do it indiscriminately. Don't just do it. Do it because you truly suspect heart failure. So, if you do that, and I guess I slept until about 9 this morning at the hospital because last night was rough. So you will get a copy of these. So you won't have to, I guess, annotate them later. Or I'll try to upload them during the break. I don't think this PowerPoint's uploaded. All right. So based on, I'm sure all of you took time out to listen to me over the weekend. So serial cardiac enzymes. Remember, cardiac enzymes usually are not drawn by themselves. You draw them in series. This I put as they're 6 hours apart. So this patient, the history, you'll get a little bit of history. This will feel like, this is kind of how I'm going to test you. You'll have a handful of questions on cardiac enzymes, and it will look very similar to what this looks like. So important that I hope you get this either now or after the fact. So this is a patient who was found down. Last seen 2 days ago. He's unconscious. Maybe you look on his back, it's really red. It looks like he was in the same position for a long period of time. These are the cardiac enzymes. Can anybody tell me, based on what I presented to you, what is the most likely interpretation of this result? You were unsure. Let's start.
Yeah, well, the troponins right below, it's below 0.5, so
Okay.
I wasn't sure if it's 0.5 or 0.05.
Now, so the troponin, so in parentheses is normal, so that just means it's undetectable. So you interpret it that way. So if it's undetectable, then what? Well, so you gotta look at everything else. So what do you think this represents in the clinical setting that I just gave you?
CK index is below 3, so most likely this drug is on or
Okay, so now somebody want to give me the more specific term? I know somebody, I don't know, somebody just shout it out. Yes. Exactly, rhabdomyolysis. So the key here is, everything else is pretty negative. This elevation, the CKMB elevation is insignificant. That's very low. But what's very, very, what should jump out at you is this extreme elevation in CPK. If you get an extreme elevation in CPK, especially if it's by itself, could it happen along with an MI? Could that happen? It could. But what I'm telling you is this elevation in CPK into the thousands or into the tens of thousands, especially in the setting of someone who has reason to have possible muscle breakdown. Rhabdomyolysis is a consideration, and the reaction to it, number one, is then this person gets daily CPK. We got to keep an eye on it. Number two is aggressive, not adequate, aggressive, actually, not just adequate, but aggressive IV fluid hydration. Why? Anybody remember why? Why do you care? Rhabdo. Sorry. Yes. So the myoglobin will actually clog up the renal tubules. You will go into kidney failure. You'll get this characteristic urine that is like Coca-Cola colored and then eventually decrease in quantity. Creatinine will go up. Dialysis may be required. Yes, this happens. It happens frequent enough. This is not rare. This happens relatively frequently. If you don't jump on top of rhabdo and hydrate the crap out of it, you want to see urine output at least 100, 200 ml per hour. This person needs to be just peeing out. Usually we monitor with a catheter, put a Foley in, and urine output needs to be significant. Step two, if you really want to be more aggressive, and sometimes a nephrologist will do it, sometimes we'll do it. If you're afraid, you want to then alkalize the urine. And the way we accomplish that is by giving sodium bicarbonate infusion. So that would be second line treatment for rhabdo. Number one is hydrate, hydrate, hydrate. Number two, consider adding sodium bicarbonate infusion. Instead of regular IV fluid, you do sodium bicarb. And in the next lecture, I begin to introduce you to the concept of IV fluid therapy. And sodium bicarbonate is one of the things that we order very commonly. And we can clear that up at a future date. So what's important here, this is rhabdo. So in the absence of CK index elevation, in the absence of an elevation in troponin, even if it's just CKMB and CPK, remember CKMB is not as specific, so that can elevate in the absence of MI, but the CPK is very non-specific. What's the other thing that I talked about that you probably won't see but ends up being even less specific than CPK that might be detectable 1 hour after myocardial injury?
Myoglobin.
Myoglobin. Again, it's not, you're probably never going to see it, but I think that it's still, it's useful. It's really, if you really are super paranoid and you think someone's having an MI and chest pain just started now, the only thing that might elevate in the first hour or two is maybe myoglobin. But again, it's not something that I've seen at Lee. I'm not sure if places like Clewiston or other places might have it. But otherwise, you need to understand that things don't elevate for several hours, which is why you have to always order serial enzymes. If you ever consider ordering a set of cardiac enzymes, don't just order one set, at least order one more set. If you really, you can order, sometimes I'll be lazy, it's not even lazy, but I don't want to hear nurses say, we can't get blood. So I'll order one like now, and then one 12 hours from now, which is enough to satisfy me that at least you have something to detect if there's an elevation. But the right way to do it really, Q6 hours, 3 draws, would be the way that, at least initially, you should learn it. So that's the answer. Any questions? Scenario number 2. And now, when you look at these, again, I would stress to you that you look at the pattern, and then based on what you've learned, you are going to tell me what it is. So here you have a pattern. And this is a patient who came to the ER this morning, and again, look at the pattern, look at the scenario. I usually, if I tell you something, I give you a scenario, especially in a test question, it's usually gonna be helpful to some degree. Came to the ER this morning having indigestion that's been on and off for the past week, but this morning he felt tired and winded, and this is what brought him to the ER. So it's not even the indigestion. He's like, I don't feel right. This doesn't feel normal. So looking at the pattern, who wants to tell me what they think is going on? And again, this is something where I almost encourage you to think outside, like what would cause this pattern? So it's not, the way I put on there is not accidental, really, seriously.
I don't know, I started by looking at the troponin, it
Yeah.
looks like it's trending down.
Okay.
So maybe the patient did have some kind of MI, but it was, troponin starts appearing between 4 to 6 hours and it peaks at, I think, 18 to
Correct.
24. So I think they had something that probably yesterday or the day before and it's getting better.
So what if I told you, yes, so I agree with you. So the troponin now, again, so you're looking at this pattern, but look at it in context with this pattern here. And then what if I added that around 6 o'clock in the morning, his indigestion got really bad, but he took Tums and he swears it got better. But he'd had this really bout of indigestion, maybe accompanied with some shortness of breath. It was like the worst he ever had, but it got better. Then looking at the pattern, what do you think possibly explains that? Because you're right, but yeah. So another incident, something happens. So this is intermittent, and that's the clue I try to give you. So it's intermittent, but then something happened, and that's what elevated the shorter term stuff. So yes, you're right. Troponin elevation, remote, persists for approximately how long? 10 days, roughly. I mean, it really can persist for a while. So if someone comes in a week later, you can still have an elevated troponin, but you won't look at that trend. So if it's elevated just like mildly, but it's on its way down, and the complaint was something that happened remotely a few days ago, that can explain that it's remote. However, if you do end up getting an elevation in your other indices, so the initial CPK, CKMB, CK index were kind of unremarkable and negative, but over here somewhere something happens, so he begins to elevate, and then the troponin starts to tick up a little bit at 1400. So basically what I'm trying to teach you here is that what's good to detect a second event after you've already had an elevation in troponin is going to be your other indices. So in the back first, then
How high does troponin go? Like, one goes like 10, and so that like long time after?
I've seen it, the highest I've seen is up in the 50s, and I'm not sure, potentially it can be higher than that, but the highest I've seen is in the 50s.
So that could be like up to like 9 days after.
Yeah, I mean, possibly, but what I would tell you is that, the number, I wouldn't necessarily link it to severity of MI. You would, and conventional wisdom would dictate, sure, I mean, it only makes sense. Thing is, I've seen cardiologists, we had a troponin, I'll never forget, we had a troponin by 22, and then we get cardiology consult, and they come in, and I'll never forget, because even my intensivist was like, what? Cardiologist comes in and says, nope, that's not MI. And then we're like, so why? I mean, this is pretty bad. You guys have told us someone's had an MI when they have a troponin of 0.5. And he went to really explain, he said, listen, no EKG changes, and the echocardiogram is normal. I'm sorry, that's not an MI. That's demand-mediated ischemia that maybe was pretty bad in the moment, but I do not see evidence of MI. No, he doesn't have one. We're like, all right, yes, that's your specialty. We're not going to argue with that.
If you have an increase in the CPK or the index of 1400, would you care about that little increase in the troponin?
I mean, so if you didn't have, so the question, if we didn't have the elevation in the other indices and that troponin bumps up a tiny bit, would you care? Obviously you want to look at it critically. And what might have happened? Again, remember that an elevation in troponin by itself could be a microinfarct. And if that's happening, it's probably because of some event that had to do with, again, O2 mismatch, myocardial O2 mismatch between what it's getting and what it needed. So incidents with issues like hypertension, hypotension, severe sepsis, something that's causing the heart to starve can cause a small elevation of troponin, but it not necessarily be MI, but it'll be due to somebody having some sort of heart disease. So, again, in this country, unfortunately, and most of the world, you assume as people age, you're going to have some sort of coronary artery disease. So on a normal day, and maybe even on a normal day with exercise, you're fine. But when you get something extreme happen, like we get people, in the hospital who end up with elevated heart rates 170 for a while, for whatever reason, rapid atrial fibrillation, SVT, or what have you, ventricular tachycardia, another arrhythmia, or hypotension, hypertension, any of those type of events can result in an elevation of troponin that is not due to MI. But if someone gets an elevation of troponin, it should be concerning enough that cardiologists should be involved, and they get angry, like, this is the most common cause of cardiology consults. And I say, well, job security helps pay for your boat and everything. So those patients warrant a workup because they probably have some disease, and let the cardiologist then stratify them into whether they should get a stress test or even a cath. So even though they might say, no, this is not an MI, no, troponin elevation, not an MI, but we are going to cath them. Or, yep, we're going to do a stress test. Why? Because that's not going to happen if you have clear coronaries, or at least the initial assumption should be it shouldn't.